Hello everyone, I'm Kamran Barin. I'm coming to you from Columbus, Ohio. It's a pleasure to be here with you. Just before we get started, a quick disclosure. I'm a consultant to Inner Acoustics Denmark and Bertec Corporation here in the United States. Today's topic is the caloric test. The caloric test is probably the oldest test that we have for evaluating vestibular function. Over the years, sophisticated instruments have been developed for delivering precise caloric irrigations and recording the resulting eye movements. But if you look at the fundamentals of the test, they're about the same as what was described over 100 years ago. The caloric test is considered a very useful test of the vestibular function because it allows us to detect unilateral vestibular abnormalities. And the reason for that is that the caloric test is one of the few tests where each labyrinth, right and left labyrinth, can be independently tested and evaluated. Now, the caloric stimuli are not the natural stimulation to the vestibular system. Head movements are the physiologic and natural stimulation. But unfortunately, under most conditions, head movements stimulate both labyrinths, and you cannot restrict the stimulation to one labyrinth at a time. Instead, over the years, the caloric irrigations have been used as a more practical method for testing vestibular function in a clinical setting because, again, you can deliver the stimulus to each ear independently. Let's review physiology of the caloric test. For caloric testing, the patient should be placed in a supine position with the head or the upper body elevated 30 degrees as you see in this figure. This head position will place the lateral semicircular canals in the plane of gravity as is shown in this figure. If you look at the patient from the front, you see the orientation of the semicircular canal, in this case the left lateral semicircular canal here. When there's no irrigation, the neural firing from both the right and left ears are approximately the same, so there's no sensation of motion or any type of nystagmus in a normal individual. The most common method for the caloric testing is the bithermal calorics, where the external auditory canal in each ear is irrigated twice, once by a medium which is slightly higher temperature than the normal body temperature, and once with a medium that's slightly cooler than the normal body temperature. So here, if you start irrigating the external auditory canal with a warm medium, the area of the semicircular canal that's closest to the external auditory canal is going to get heated up. And the endolymph in the semicircular canal, because it gets heated up, it gets lighter and it will rise. This rising of the endolymph will put pressure on the cupula, bend the cupula toward the utricular sac. This kind of cupular deflection in the lateral canal would cause excitation of the semicircular canal. So in this case, the irrigated ear has a higher neural firing than the non-irrigated ear. That will give the sensation to the patient that they're rotating toward the irrigated ear, and as a result, the vestibular ocular reflex will move the eyes slowly away from the irrigated ear, and then the fast phases of nystagmus will bring the eyes back toward the irrigated ear. So for example, in this case, if this is the left lateral semicircular canal, the patient will have left beating nystagmus. Now, if you irrigate the ear with a cool temperature, this time the endolymph will get heavier, will sink, and will pull the cupula behind it. This type of cupular deflection away from the utricular sac in this position will cause inhibition of the semicircular canal, and the neural firing will decrease. Because of the tonic neural activity on the opposite ear, is higher than this, now the patient will feel like they're rotating toward the non-irrigated ear or away from the irrigated ear. And again, the vestibulo-ocular reflex will move the eyes this time toward the irrigated ear, with fast phases being directed away from the irrigated ear. So this leads to the Cow's rule, which describes the direction of the evoked nystagmus to the side of the irrigation. So cool irrigations will generate nystagmus that beats opposite to the direction of the irrigated ear, and warm irrigations will cause nystagmus to beat toward the irrigated ear. So in this example, cool irrigation will cause right beating nystagmus because this is irrigating the left ear. Now there's another position where you can actually do caloric testing, and that's the prone position with the head moved downward 30 degrees. In this case, the lateral semicircular canals are again in the plane of gravity, except that it's flipped 180 degrees. So in this orientation, or in this head position, if you irrigate the ear with a cool temperature, this time the endolymph again will become heavier, will sink down, but this time the cupular deflection is the opposite of what it was before, and this time the cupula will bend toward the utricular sac. This will cause excitation from the irrigated ear, and which is the opposite of the what you saw in the standard caloric position. In this position now, the nystagmus would be in the opposite direction. This is, if you want, you may want to call that walks, which means warm opposite, cold same. There's a slight difference between these two positions. The caloric stimulation has two components. One of them is gravity-dependent component, which I just described. There's another component, which is a direct stimulation of the nerve. Direct neural stimulation, when it's heat, it causes increase in neural activity. When it's cool, it causes decrease in neural activity. That component is very small, but in these two different head positions, it has a different effect. So in the standard caloric position, the neural component and the gravity components are in the same direction. They enhance each other. In the prone position, they're in the opposite direction and they subtract. So in fact, you get a little bit stronger response in the standard caloric position, and that's why we do the testing in this position. The prone position used to have a application for the ice water testing. We don't do ice water that much these days, but it was a very interesting and effective way to determine a person who had strong spontaneous nystagmus, and if you were doing ice water, to determine whether there's a change that you're seeing is actually a caloric effect or if it's just spontaneous nystagmus. If you change the patient's orientation from standard caloric position to the prone position, if the nystagmus changed direction, we knew that there was a caloric response. If the nystagmus did not change direction, we knew that there was spontaneous nystagmus. So, a quick summary of advantages and limitations of the caloric testing. The most obvious advantage is what we talked about before. Unlike head movements, caloric irrigations can be delivered to each labyrinth independently, and that makes it very effective for detecting unilateral vestibular losses. Also, the other advantage is that caloric stimulation can be generated by relatively small sized and inexpensive equipment. So, for example, compare that to rotation chair, caloric stimulation can be delivered in a much smaller area. But the caloric testing also has a number of limitations that we should be aware of. The first limitation is that the responses are not calibrated, which means the responses vary from one person to another person, and sometimes even from one ear to another ear, because the whole basis of the caloric test is the heat transfer from external auditory canal to the labyrinth. So you can see that that will depend on the anatomy and many differences. So if the person has, for example, one person has a response of 20 degrees per second caloric peak response, and another person has 10 degrees peak response, you really can't say that one person's labyrinth is more sensitive than the other person, because it might be just that the heat transfer is not as effective in one person compared to the other. Another limitation of the caloric testing is that it's obviously a test of the lateral semicircular canals. Technically, you can test the patients, you can put the anterior and posterior canals in the plane of gravity and try to do caloric testing, but they're too far embedded in the temporal bone, so you cannot really reach there easily. The heat transfer doesn't reach there easily. So the caloric testing is primarily considered a test of lateral semicircular canal and superior portion of the vestibular nerve. Another limitation of the caloric testing is that it's generating very low frequency stimulation, which is not really in the physiological range of the vestibular system. For example, the rotation chair, you can go up to 1 hertz, about half a hertz, which is the physiologic range, but in the caloric testing, it's an extremely low frequency test. Another limitation is that the patients usually find the caloric testing distressing. They're not very well tolerated by some patients. Finally, what makes it really attractive for unilateral losses, which means comparing the right and left ear, it's actually a limitation when it comes to abnormalities that affect both vestibular systems simultaneously. For example, patients who have bilateral hyper or hypofunction, the caloric testing is not the most effective test for these patients. So here, just a quick review of the irrigators. The caloric irrigators, there are 2 different kinds that are currently accessible. Open loop water, it's called open loop because the water just goes into the ear canal and comes back, and you're supposed to catch that with a basin. Open loop water, technically for the examiner, it's very easy to do. You just basically put the water in the ear and you get the response. You usually get robust responses, which means you're getting strong stimulation, and usually the patient has strong responses. But for that reason, most patient finds water irrigations unpleasant. Now, air irrigations have been around long time now, maybe since 1960s or 1970s. Well, obviously they're not as messy as the open loop water. There's no water to catch. They're more comfortable to the patient because, again, they don't generate as strong a response. But the downside with air is, as a technician or as a person who's performing the test, it needs a much higher technical skill to administer it effectively when compared to water. There are a number of other things to be considered that we need to consider with air irrigators. The air irrigators, the design of the irrigator tip may affect the temperatures in the ear. So basically follow the manufacturer's recommendations of how they tell you to do it and what temperatures to do, because they must have gone through the testing to determine exactly what the temperature is in the ear canal. For example, an irrigator where the air freely goes in and out will have a different temperature in the ear canal compared to an irrigator where this seals the ear canal and doesn't let the air come out. So again, just follow the manufacturer's recommendations. Be aware that some air irrigators do not cool the air. They only use the ambient temperature. So if you're in a warm climate, you might not be getting what you think as far as the cool irrigations. This question comes up frequently. Which one is better? Usually whichever one you have experience with, air or water. If you continue using that, if you're comfortable with it, and if you're doing it correctly, both will generate, both modes of irrigations will generate acceptable results with good retest reliability. The standard parameters for water and air irrigators are given in this table as far as the volume, duration, and temperatures are concerned. You notice that the temperature differences for warm and cool irrigations are higher for air irrigators compared to water irrigators. That's because the air has a lower capacity to retain heat, and that's why these numbers are larger for air. If you use these standard parameters, then the normative values that we'll talk about a little bit later on will directly apply to your clinic. You can use that. If for some reason you're using numbers that are slightly different, you should still be able to use the normative values. But if there's for some reason you're using something that's substantially different, then you probably have to develop your own norms. So the procedure, most of you are familiar with it. First, you should describe the procedure to the patient, and without scaring them, but accurately describing what will happen to them. Most patients are worried that they will be sick, so you need to reassure them that in most cases this is not that will not happen. I'll talk about this a little bit later. I think there are procedures that you can follow in order to minimize the chance of the patient discomfort. So you begin the first irrigation by closing the goggles, eliminating fixation, starting the eye movement recordings, starting the irrigations. And irrigation usually depends on which mode you're using, either ends after 30 seconds or after 1 minute. So as soon as the irrigation is done, you should engage the patient with some alerting tasks so they're awake and alert throughout the rest of the test. After the response reaches the peak and then starts subsiding, which usually occurs about 40 to 45 seconds after the end of the caloric irrigation, you should ask the patient to fixate. Most of the goggles, V&G goggles now, have a light built into them, and the light can come on and the patient can fixate. And you can look at the patient's pupil. When they shrink, you know that the patient is actually fixating. In the old days, you may have needed to remove the goggle cover and ask the patient to look at the fixed target. You do this for about 10-15 seconds. There's really no exact rule here, and after 10 seconds or so you can again remove fixation and put the goggle cover back on. Continue the recording until the nystagmus goes away. That's usually about 2 or 3 minutes from the onset of the irrigation. You wait a period of time, which we'll discuss in a minute, and then you perform 3 more of those irrigations the same way. Now, some of the practical issues that I'm sure based on that description, some of you may have questions. In the old days, and even now, ANSI recommendation is that you calibrate eye movements between irrigations. British Society of Audiology, which also has standards for caloric testing, early on matched the ANSI standards, but later on they reversed. That kind of recommendation was for ENG. and non-computerized strip chart recording systems. For VNG, actually calibration between irrigations might create more variability, so it's not recommended. If you have a good calibration, go with it for the entire test. So what order should you do the irrigations? Both ANSI and BSA recommend that you start with warm temperature. And that's a good recommendation, especially if you, at some point in time, you decide, okay, I just want to do 2 irrigations. In other words, if you want to do monothermal calorics. Monothermal calorics is more effective with warm irrigations. So there's a good basis why you should start with warm. But a study in 1988 showed that if you do start with warm, because warm is an excitatory response, usually the very first irrigation is stronger than the rest of them. So once the patient is a little bit hyper alert and they get the warm irrigation, they might get a strong response. And then the remaining 3, they don't have as strong a response. So this causes a little bit of a temperature effect. So usually your warm irrigations are stronger than your cool irrigations. And the study showed that if you do start with cool irrigations, you don't get that difference as much. So if you're going to do all 4 irrigations, it might be best if you go ahead and start with cool. But if you ever think that you're going to stop and after 2 irrigations, then definitely start with warm. As for how long you should wait between irrigations, ANSI recommends a fixed period of time, around 5 minutes, between the start of consecutive irrigations. This recommendation doesn't differentiate between a person who has a very strong response and somebody who has a weak response. British Society of Audiology recommends a minimum of 7-minute interval between the start of consecutive irrigations. 7 minutes and longer is usually enough for even a patient who has a strong response, so that recommendation will work. But in order to save some time, what you can do is wait for the previous caloric nystagmus to subside, and then from that point on, just wait a fixed amount of time, like 3 to 5 minutes. That will ensure that the effect of the previous irrigation has subsided. For those of you who use air irrigators, you might be interested to know that the ANSI actually disallows use of air as a mode of irrigation. They recommend either open loop water or closed loop water. Closed loop water systems are no longer manufactured, so for the only mode of irrigation for ANSI currently is open loop water. Unfortunately, I think ANSI made their recommendations based on outdated studies, and the users have not really followed that recommendation. The ratio of air to water irrigator sales is about 4 to 1, so the customers mostly prefer air for the same reasons that we have discussed before. The only thing is then if you are using air irrigators, you can continue using them as long as you have technically managed them and you have gone through the learning period to use them effectively. The next issue that I'd like to address is how many fixation suppression tests should you do during the caloric test? Technically, you need a minimum of 2, 1 for each direction of nystagmus, but it's best if you go ahead and do this for all 4 irrigations. That way, as I will explain later on, you will see it on the graphs easier, that if you have, you can choose the 2 irrigations for 1 for each direction, where the nystagmus intensities right before the irrigation are approximately the same. That's a fair comparison. That's how fixation suppression for the right and left should be compared. How about doing monothermal calorics, cool or warm? Is that enough? Well, you should realize that you can do monothermal, but if you use the standard parameters, normal values, your false positive rate will be very high. You also will miss the opportunity to identify some of the artifacts. There is a possibility of using the monothermal calorics as a screening test, primarily to identify normal calorics. A study in 2009 has laid out nicely the conditions or the parameters that must be satisfied for this type of testing. First of all, no oculomotor abnormalities. Second, no gaze or spontaneous nystagmus. And finally, the difference between peak responses should be less than 10%. And you should use warm irrigations, as I mentioned before. If all of these three conditions are met, then it's very likely that your calorics are normal and you can stop after 2 irrigations. You can also relax this conditions a little bit if you're including another test. So for example, if you have a V-hit and your V-hit is normal, then 2 irrigations probably adequate if they also show minimal amount of asymmetry. Some of the other practical issues. How do you reduce the chance of the patient becoming sick? Usually the patients are, most of the patient discomfort occurs during the first irrigation. So if you can manage the first irrigation, usually you're okay for the rest of the irrigations. So I usually pay attention to the patient's body responses. You know, when the patient's breathing gets heavier, and if you can feel the heat rising from the patient's body, then you know that the patient is under a little bit of distress. And then if you get to a point where you feel like the patient might get sick, before that, interrupt the irrigation and just make a note of the time. So for example, if you were in the middle of a 1-minute irrigation but you only did 40 seconds, just make a note of 40 seconds and allow time for the patient to recover, and then after that all the remaining irrigations just use 40 seconds of irrigation. If the patient is getting too distressed, one of the things you can do is you can sit the patient up, turn the head 30 degrees downward. That will place the lateral canals in the horizontal plane, basically will stop the endolymph flow, and the patient might recover quicker. Of course, you have to do that before the patient gets to a point of no return. How about vertical nystagmus during the caloric testing? Actually, vertical nystagmus is quite common even in normal individuals and patients with different abnormalities. The most likely cause of this is that there is some minimal stimulation that reaches posterior anterior canals, and the vertical nystagmus is originating from those canals. In the old days, there was some discussion about the caloric perversion. Caloric perversion, by definition, all 4 irrigations must generate either purely vertical nystagmus or vertical nystagmus that's much stronger than the horizontal nystagmus. This I've never seen, and I have not really seen a convincing case in my own clinic or other clinics. I think this was mostly an artifact of old test methods of not recognizing some of the potential reasons for this. For example, crosstalk between the horizontal and vertical channel. It was considered a central abnormality, but it's extremely rare, and in most cases, if I see something that's close to that, there's a much simpler, easier explanation than something like caloric perversion. Is there an age limit for caloric testing? There is no upper age limit, but you should realize that sometimes irrigations in the older patients are not as effective. So maybe due to the thickening of tympanic membrane, otosclerosis, or something like that. Sometimes the caloric irrigations generate minimal responses, and you might think that the patient has bilateral weakness. And you might think that, well, that's just the deterioration of vestibular system because of age. But in most cases, if you put the patient on use a different mode of vestibular stimulation like rotation or VHIT, you'll see that these patients have normal responses. So it's most likely because of a heat transfer issue in the older individuals, and you should be aware of that. As far as the lower age limit, children and adults with developmental delays, usually about 5 years is the minimum age that you can test the patient. If the patient is really cooperative, you can go a little bit lower than that. Not cooperative, you probably have to go higher than that. But if somebody calls and asks you, can you test a 2-year-old, the answer is most likely no, because children that age do not let you put an irrigator in their ear and hold it there for such a long time. So the caloric testing you can't really, it's not a optimal test for pediatric population. So how do we analyze the results? There are 3 time periods in the caloric response that need further attention. Most of the computerized system, VNGs, the computer will do this for you, but you still have to make sure that you follow certain rules to make sure that the computer is managing these data profiles appropriately for you. They all have a very similar pattern. They start at the baseline. If the person is normal, has no spontaneous nystagmus, that baseline is about 0 degrees per second. Then from there, the nystagmus intensity rises. And about 30 seconds after the end of the irrigation, so in case of water, that's 60 seconds. In case of air, that's about 90 seconds. So after 30 seconds, the response reaches its peak. And from that point on, the nystagmus starts declining. Shortly after the decline of nystagmus, if you present a target to the patient, the nystagmus will drop down because of the fixation suppression. Once you remove fixation suppression, once you turn off the dot, the nystagmus goes back up and then gradually declines over 2 or 3 minutes. So the 3 time periods that you need to pay attention to is the first 10-15 seconds of the at the beginning of each irrigation. That period of time tells you whether the patient has spontaneous nystagmus or not. That part should match what you see in the positional testing, specifically in the static position testing. Then about 60 to 90 seconds after the start of the irrigation, this is where the response should reach its peak, and this is what you use for further calculations. So you need to pay attention, make sure that the area is correctly identified by the computer algorithm. And then shortly before or shortly after the fixation, you need to determine this intensity of the nystagmus. That tells you whether the patient is suppressing the nystagmus appropriately or not. So the data analysis, once you determine the peak responses for 4 irrigations, you have right cool, right warm, left cool, left warm. These are 4 values, each representing the peak response from the irrigations. You also need to identify 2 time periods right before and right after fixation here. Now, this is what I was mentioning. In this patient, because of the unilateral weakness that we'll discuss in a minute, the nystagmus intensity for one ear versus the other is quite different. So if you try to compare the fixation suppression for right warm and left warm, because the starting nystagmus is very different, it's not a fair comparison. In this case, you can use the left cool and left warm because they have about the same level of intensity of nystagmus right before fixation. So when you're doing this, avoid the nystagmus beats that are very close to the when the dot comes on, so the target comes on. Wait a second or two before you measure the nystagmus. The next step here is determine the total response from the right and left ear separately. So in this case, for example, the total response is that opening of this pod here. It's about 12 degrees. This one is about 54 degrees. The first test you want to do is determine whether you have bilateral loss. Now I'm using this 12 degrees per second limit. I will talk about other studies that use different limits, but for now let's just go with this, and I'll explain this a little bit later in more detail. So if the response from both sides, both right and left, are less than 12 degrees simultaneously, that means that the patient more than likely has a bilateral weakness. Now, in that case, you should stop. You should not calculate unilateral weakness directional preponderance, as we'll talk about in a minute. Those values are usually not valid anymore. In this particular case, one side is 12, but the other side is substantially higher than 12, so this patient definitely does not have a bilateral weakness, so you can proceed with the rest of the calculations. As you see, again, the computer takes care of most of these for you, but you should be aware what the computer is calculating, so you can, again, if there's a problem, you can recognize that. The test parameters, the most important test parameter in the caloric testing is unilateral weakness. It's also known as canal paresis or reduced vestibular response. It shows the relative difference between responses of right and left ears. The terminology that we use is that X percentage of unilateral weakness in the weaker ear. So for example, we say 64% unilateral caloric weakness in the right ear, or something similar to that. This is a very high clinical value. In fact, one might consider this the highest clinical value for detecting vestibular abnormalities. The way it's calculated, and again, we don't need to know that because the computer does this for us, but it's basically you take the total responses from the right ear, subtract the total responses from the left ear, and then normalize it by dividing it by the total response, total right and left response. So here the total response is 66 degrees per second, and the unilateral weakness is 64%. Another parameter that's commonly calculated in the caloric test is directional preponderance. Directional preponderance, unfortunately, is a very low clinical value. It's misunderstood, and in recent years, there are many laboratories that have stopped using it, and I'm in favor of that. I think directional preponderance gives you misleading information. Directional preponderance, as it was originally described, is the relative difference between right beating, left beating nystagmus. So you take the total irrigations that are generated, that are supposed to generate right beating nystagmus, you subtract the total value of the irrigations that are supposed to generate left beat nystagmus, and then you normalize it by dividing by the total response. What happens is that directional preponderance can be caused by two different factors. The most common factor is if you have spontaneous nystagmus. So the baseline of all the caloric irrigations will shift one way based on the slow phases of spontaneous nystagmus. This is the most common method, and instead of trying to use directional preponderance to diagnose that, well, you can do that interpretation much more easily based on the spontaneous nystagmus. There's an extremely rare type of directional preponderance where the irrigation results for one direction of nystagmus are higher compared to the other direction without any substantial spontaneous nystagmus. So this is an example of it. Again, an extremely rare finding, and we really don't know what it means because the incidence of it has been so low that we just don't have enough information to judge that. The next parameter that we use is the fixation index. Fixation index is a measure of nystagmus intensity during fixation compared to the nystagmus right before fixation. So we need to do this for both right beating and left beating nystagmus because in some cases this fixation suppression is normal for one direction but not normal to the other direction. The most common formula that you use is the spontaneous slow phase velocity right after fixation, and you compare that with the slow phase velocity right before fixation. So the nystagmus right about here and right about here, those two are divided, and it gives you a percentage as you see here, 22%, 27, 29%. It was not performed for right cool. There's an alternative formula that was recommended by British Society of Audiology. I'm not too crazy about that because it depends on how long you do fixation, and if you have only 5 seconds, you're going to get slightly different numbers here. So at any rate, the fixation index is the ratio of the nystagmus right after fixation compared to right before that. So once you calculate those parameters, you have to decide whether these are normal or abnormal. The most common parameters are given in this slide. For bilateral caloric weakness, I use the criteria that the total responses from both ears should be less than 12 degrees. But if you read the literature, there are literally dozen different criteria for determining bilateral weakness. The reason for that is that the caloric testing is not an appropriate test for bilateral weakness. So depending on what sample you have, you're going to get a different number. So the number of different methods that have been used for identifying bilateral weakness has been, for example, total responses less than 30 degrees per second. That total, I mean right and left. This is from older data from 1960s and 70s. In 1980s, the criteria was total of 22 degrees per second for all 4 irrigations. And then there's a British Society of Audiology that all 4 irrigations, each one of them has to be less than 8 degrees per second. So again, for bilateral weakness, the best method is that if you suspect bilateral weakness, then you really need to do another test to verify it. So anything that comes close to any of those criteria, take that as a sign that you need to do another test. As I said, I use if the total response from both ears are less than 12 degrees per second simultaneously. For unilateral weakness, the abnormal limit is usually, or normal limit is usually less than 25%. Some laboratories use less than 20%. And people sometimes ask me, well, which one is better? Again, there's no magic number here. If you use 25%, your false positive will be low, your false negative might be a little higher. If you use 20%, your false positive will be higher, your false negative will be lower. So what you feel comfortable with for your clinic, any of those numbers, 25 or 20%, should be fine. Directional preponderance, as I mentioned, I don't use that anymore. Most laboratories that use it use 30% as a normal limit. if you are going to use it, I would say at least try to separate the baseline shift, the one that's caused by spontaneous nystagmus, from the true gain asymmetry. If you do that, you can interpret the baseline shift according to the limits of spontaneous nystagmus, like 4 degrees per second. Gain asymmetry, we don't really know what's the normal value for that, and that's another reason that I think we should abandon directional preponderance as a parameter of the caloric testing. Fixation index, the number that comes from the literature is 60%, but if you use 50%, it makes life much easier. Then you don't have to do any calculations. If the nystagmus before, after, if it's reduced by at least half, then you can consider that normal. As for hyperactivity, just like the bilateral weakness, whenever both ears are involved, the caloric test doesn't really have good criteria for these types of situations. So for hyperactivity, I usually use total response from either the right ear or the left ear if it exceeds 140 degrees per second. And if you want to know where that 140 degrees comes from, it's 60 degrees for cool irrigation, 80 degrees for warm irrigation. Those are the numbers that have been around for many years. So how do we interpret the caloric test? The summary of interpretation is here in this slide. So first of all, the caloric test, as you can see here, is the test of the lateral semicircular canal and the superior portion of the vestibular nerve. You might ask then, why are these other central pathways are involved in the caloric test? For example, vestibular nuclei, oculomotor nuclei. The fact is that the caloric test, the caloric responses do go through these pathways. What makes the caloric test a test of peripheral vestibular function is the fact that we repeat the caloric tests with warm and cool irrigations for the right and left ear. So when you take the total of the right responses and you subtract the total of left responses, you basically subtract the common pathways, which is the central part. So what's left for you is the lateral semicircular canal and the superior portion of the vestibular nerve. But remember, that calculation is only done for unilateral weakness parameter or canal paresis parameter. So that's the only one that actually indicates peripheral vestibular function, which involves either the lateral canal or the superior portion of the vestibular nerve on the weaker side. In the acute phases of abnormality, oftentimes the patients will have spontaneous nystagmus. The spontaneous nystagmus will shift the baseline of the caloric testing, but should not affect the total response from each ear. Unilateral weakness can be caused by diseases that affect the labyrinth, the vestibular nerve, or the blood supply to those peripheral structures. Other abnormalities, for example, directional preponderance, bilateral weakness, hyperactivity, failure, fixation, suppressions, these are actually not peripheral findings. They're either non-localizing or in other cases they are central findings. So this demonstrates a normal response. As you can see, all 4 caloric irrigations are approximately the same intensity, same profile. If you put them in a caloric pod, you can see they all rise from the baseline of 0 degrees per second. They peak all about the same value of around 20 degrees per second, and then decline, and the patient can suppress. So here, if you pick the peak of the responses appropriately and look at the nystagmus during fixation, you should come to easy conclusion that this is a normal response. Now, the most common abnormality in the caloric test is the unilateral caloric weakness. The first one, you can see that the responses from the right ear are substantially lower than the responses from the left ear, that total response from each ear is signified by the opening of this pod. So the opening of the pod for the right ear is much smaller. That indicates that there's a unilateral weakness in the right ear. That is in the calculations. You see 64% unilateral weakness in the right. Can we say anything else about this test? Because all of the tests are centered around 0, that means this patient has no spontaneous nystagmus, which really what it means is that this is more than likely it's a chronic lesion. It's a statically compensated lesion. If it was an acute one, you'll see all the irrigations shifted to one direction or another. So that's, for example, here. You see that this patient has a slight unilateral weakness, about 31% in the right ear, but all of the irrigations are shifted toward the right cool and toward the right warm, which means that's a left beating nystagmus. And that's what you would expect. A patient with a right-sided lesion, an acute right-sided lesion, should have a left beating spontaneous nystagmus. If you look at the intensity of this nystagmus around time 0, it's about 10 degrees per second. You should have seen that 10 degrees per second during the static position testing, specifically in the supine position. So this represents an uncompensated or an acute lesion because there's a significant level of spontaneous nystagmus. So as we mentioned, the criteria for abnormality is 25%. Some people use lower, like 20%. The localization of the unilateral weakness is that it's a peripheral vestibular lesion involving the lateral semicircular canal, or its afferent pathways on the weaker side, which is usually the superior portion of the vestibular nerve. This can be caused by diseases that affect the labyrinth or the vestibular nerve, or the blood supply to those sites. So in an uncompensated or acute version of this, it could be viral or bacterial labyrinthitis, it could be vestibular neuritis, it could be Meniere's disease in initial episodes, labyrinthine concussion, labyrinthine infarction. So in the acute case, you have the weakness along with the significant spontaneous nystagmus. Once you get to the statically compensated or chronic stage, the spontaneous nystagmus will disappear, but the weakness should remain as it was. As long as the lesion is stable, it should remain. So, for example, viral or bacterial labyrinthitis or vestibular neuritis, they have a both acute phase and a chronic phase. Meniere's disease in late stages, you will end up with a permanent weakness, whereas in the Meniere's disease in initial episodes, you'll have a weakness, or at the beginning of the episode, in the initial phase of the Meniere's, you might have a weakness, but then the weakness disappears as the patient gets further away from the onset of the episode. Vestibular schwannomas, they usually do not have an acute phase, because if the tumor is growing slowly, the patient incrementally compensates for that. Central lesions that affect the root entry zone of the vestibular nerve, such as multiple sclerosis, if the plaque involves the root entry zone of the vestibular nerve, these patients often have caloric weakness, but usually there are other central signs which then can differentiate this from true peripheral vestibular abnormalities. So directional preponderance, most people use 30% for as an abnormal limit or normal limit. Again, the localization, it doesn't have any localizing value, and again, I personally just look at the spontaneous nystagmus rather than looking at the directional preponderance. So here's an example you saw before. In this case, the patient has 10 degrees per second of left beating spontaneous nystagmus, and that's a significant amount of spontaneous nystagmus and should be considered abnormal. In a case like this, which is extremely rare, we don't really know what the abnormal or normal criteria is, but this looks substantial enough that one might consider this abnormal. If it's abnormal, it's possible that it's because of the gain asymmetry in the secondary vestibular neurons within the vestibular nuclei. But again, we really don't know enough about this to make a meaningful interpretation. So the next abnormality is the bilateral weakness or hyperresponsiveness. The criteria, again, there are a number of different criteria. In this case, I'm using total response from both ears less than 12 degrees per second. If you look at this patient qualifies for that. This side is 5 plus 4, that's 9 degrees. On this side, it's 3 plus 3, 6 degrees. They're both less than 12 degrees per second. So this patient has bilateral caloric weakness. What does bilateral caloric weakness mean? In reality, not much. You have to have a secondary test to confirm that the bilateral caloric weakness indeed means that bilateral vestibular loss. That is not automatic because of some of the heat transfer issues that I mentioned. So for example, if somebody has bilateral atherosclerosis and the heat doesn't reach the labyrinth, so you might end up with bilateral weakness, but that doesn't mean that the vestibular system is not functioning. So you always have to have a secondary test. The gold standard would be rotation chair, at least in the past. These days, head impulse testing is a much less costly and much smaller area that it occupies, so you might try the head impulse test, active head rotation, and in the old days we used to do bilateral ice water testing. We don't do that, and it's not really recommended. So if one of these tests, specifically rotation chair or head impulse test, confirm the bilateral weakness as bilateral vestibular loss, then you can conclude that the patient has a hyperresponsiveness in both ears. The localization, in many cases, it's a bilateral loss of function, peripheral function in both ears, but you can also have central abnormalities that cause bilateral weakness. So for example, if somebody has a tumor at the cerebellum that's blocking the neural firings from reaching the central nervous system, these patients might have bilateral vestibular loss. So the etiologies, the most common etiology is unknown, but among the known causes, ototoxicity or vestibular toxic exposure is the number one reason. Bilateral Meniere's disease, congenital malformations such as Chiari malformation might be another cause. Cerebellar degeneration or tumors, as I mentioned, could cause or could show up as bilateral vestibular loss. Hyperactivity or hyperresponsiveness is a rare finding in the caloric test. The criteria, as I mentioned before, it's not very clear. What I use is the total response from either the right or left ear has to exceed 140 degrees per second. So in this particular example that you see here, the responses from both ears are extremely high, around 220 or 230. And the fact that all these 4 irrigations have been completed, it's suspicious, because a patient who has 110 degrees of response would normally not be able to complete the test. So if the patient has all these 4 irrigations, and if you see the patient really not under distress or feeling nauseous, then you have to ask yourself, is this real? It's you have to examine calibrations and consider other artifacts, because if this was truly a hyperactive response, I would have expected no more than 2 of these to be completed, and somewhere around 80 degrees per second or so, the patient would have wanted to stop the test. So if you decide and determine that the hyperactivity is real, then it denotes a central lesion. It's most likely because of the loss of inhibitory responses at the vestibular nuclei. It's seen in patients with cerebellar atrophy and diseases that affect the cerebellum. It's also been reported, at least not to this level, but at least it's been reported to a lesser extent in patients with migraine and motion sensitivity syndrome, which is understandable because there is some cerebellum involvement in these patients, so one would expect that to have strong responses to caloric irrigations. The next abnormality is the failure of fixation suppression. Again, the correct criteria is either 60% or 50%. If it exceeds that, you should consider it abnormal. So, for example, in this patient, you look at the nystagmus before and after fixation, and there's really no suppression. So this is a abnormal fixation suppression, around 95%. It's the same way for both cool and warm irrigations, so for both direction of nystagmus. I would expect this patient to also have some form of a tracking abnormality in this smooth pursuit test, because most often the fixation suppression abnormality and abnormal smooth pursuit go hand in hand. In this case, I would have expected to be bilateral smooth pursuit abnormality. If it's only one direction of nystagmus, that's seen usually in patients with unilateral tracking or smooth pursuit abnormalities. Now, one thing you have to make sure is that the patient is actually looking at the target. One quick way of determining that is that when the light comes on, if the patient's pupils shrink, that means the light is being actually observed. So if for some reason the light burns in your goggles and you don't notice it, and you think that the patient has fixation suppression abnormality, then you won't get that effect of shrinking the pupils. So once you determine that the patient is actually looking at the target, this type of abnormality is failure of fixation suppression. It's the same significance as smooth pursuit abnormalities. It's a central lesion that could be in different parts of the central nervous system, perido-occipital cortex, pons, or the cerebellum. It's most commonly seen in patients with the midline cerebellum abnormalities. Well, caloric testing by its nature is susceptible to a number of artifacts, and we have to make sure that we eliminate or recognize them before we interpret them. One of the things that happens in the computer analysis, computer tries to verify or identify nystagmus beats and then determine the slow phase velocity of those nystagmus beats. That process is never perfect, regardless of which system you use. There are occasionally nystagmus beats that are either missed or things that are identified as nystagmus beat that they're not. So you have to go, especially around the area where those numbers are important, those 3 areas that I mentioned to you. You have to make sure that the nystagmus beats are cleaned up and they actually represent the slow phase velocities. When you do that, just remember, if you have consecutive nystagmus beats, they can't be more than a few degrees apart. So if one nystagmus beat shows 20 degrees per second and the one next to it shows 5 degrees per second, one of them is not right. Which one is not right? Usually the one that has more neighbors that are like it, that's the one that you should consider. So during this process, make sure you clean up your tracings so you can get better numbers. The consequence of not cleaning up, you see this is an old caloric test, and it doesn't look horribly noisy, but you looked at like few points here that looks like outliers that the computer has picked, and as a result in the caloric weakness is determined to be 33%. But if you look at these 2 points are much different than the rest of them, and if you go clean these up, you'll end up with a caloric response that's normal. Now, I'm not suggesting that you go in and clean up everything to make it normal, but these are clearly outliers here, and you should take care of that before you interpret the results. Another types of artifacts is that when one irrigation produces results that are substantially different than the others. So for example, in the example on your left hand side, the right warm irrigation is much less than the other remaining 3 irrigations. So in this case, the prudent thing would be not to interpret it, because this is not interpretable. This will show something that's abnormal, but in fact, if you go repeat the right warm irrigation, in the majority of the cases, right warm will come back up to the same level as the remaining irrigations, and this will be a normal test. On occasion, one irrigation is substantially larger than the rest, and that typically is the first irrigation, and especially if you're using cool irrigation, warm irrigation, the first warm irrigation can be substantially stronger than the rest of them. So in that case, again, there's one irrigation that doesn't look like the rest. In this case, the right cool irrigation is much higher, and this is resulting in a number that's it's on borderline. So what I would do first, I will first try to repeat the right cool, which is very different. But if for some reason this doesn't change, I will try to repeat right warm. Maybe right warm, just like here, has been inadequate irrigation. So one way or the other, by repeating, either this will become larger and this is a true unilateral weakness, or this will become smaller and this is a normal finding. There are a few cases, recently I've seen several of these, that where the patient has one warm irrigation that's substantially larger than the other. As I said, sometimes if that's the first one, that's just the order effect, but sometimes that's not the first warm irrigation, it's the second one. And generally, you should consider this as an artifact and repeat it. But I've seen a few cases that has been repeatable. And when you look at the history of these patients, oftentimes the patient has a history of vestibular migraines. So again, don't overinterpret this, but if you see something like that, and if it's repeatable, and it's only one warm irrigation, it seems like the patient is having difficulties suppressing excitatory responses in one of the vestibular nuclei, and it might indicate something along the lines of patients with vestibular migraine. But again, this is just an anecdotal evidence. One way to figure out whether that's true or not is actually turning the patient over to the prone position, because now the excitation and inhibition reverses, and you might expect that these patients will actually have a stronger response to the cool irrigation on that side. I don't know if these patients will be willing to undergo all that stuff, but it's something that you might think about. All right, to finish up, here's the summary of the test findings, common abnormalities in the caloric test, and what their localization value is if you have a unilateral caloric weakness. It's a very high clinical value. It means a peripheral vestibular lesion involving the lateral semicircular canal or the superior portion of the vestibular nerve in the weaker ear. Directional preponderance, low clinical value, no localizing value. If you have bilateral weakness, it's a moderate clinical value. It indicates peripheral vestibular lesion in both ears, but sometimes central vestibular abnormalities can result in bilateral weakness as well. Hyperactivity is a moderate clinical value, indicates central lesion, most likely involving the cerebellum. Failure of fixation suppression, also a moderate clinical value, indicates a central lesion. So just to summarize what the caloric test, even though it doesn't identify a specific etiology, so far, at least historically, it's proven to be the most useful test for detecting unilateral vestibular lesions. With the introduction of VHIT, the need for completing a for a full bilateral bithermal caloric test has somewhat diminished, but in some cases the caloric test is still the only test that can determine the site of lesion with a high level of confidence. Thank you very much for your attention.